Thank you, Chitra, for having me here for 6 minutes. You see, Endoph is a disaster. Nobody wants to see these patients. I will just run through a couple of patients here only. This is one patient who had more than usual reaction. In fact, two of them. And here the dictum is whether it is Endoph or not, because it was referred as Endoph. So this chart is very helpful for me, where you can try to differentiate between a TAS and an infection and endophthalmitis. And if you're shifting towards TAS, so I do not give any internal antibiotics. I will load this patient with steroids by all possible routes and follow up very, very closely, maybe twice a day or so. So this was first patient which I had shown, and this patient treated with intensive steroids and follow-up. Follow-up is very essential because anytime they can tilt towards endophthalmitis. And fortunately, this patient recovered. However, if you have inclination towards endophthalmitis, like hypopyon, pupil, and exudates are there, and vision is very poor, then immediate injection is required. And when, and I think this has been covered by Srinivas also, but presently we all give Vanco-Kefta, sometimes Vanco-Amica also. But one for positive and one for negative. And always put this chart in your operation theatre wall. And this is one patient who had all the telltale signs. You see, don't expect immediate improvement. It takes a couple of days or weeks for all this synechiae to break and supportive treatment, and ultimately patient recovers. Important is to keep following him up. Other situation could be that response may not come as great as the previous one, or the situation will be so bad that patient has PL plus minus kind of vision. That means the load is very, very heavy. In such situations, you can consider intravitreal, but by and large, everybody resorts to vitrectomy. And vitrectomy has to be a radical kind of vitrectomy, and because there are two ways of entering. One is that initially, because a lot of these are hypotenuse, we do a needle infusion just to tighten up the globe, and then take the 6 mm cannula. In all this end of eye, choroid is very thick, so take a 6 mm cannula so that you are in the intravitreal space before you turn on the infusion. And sometimes it becomes a dicey job also. And the second component after you are inside is to clean up the anterior chamber. Because anterior chamber, if you don't clean up, then you do a messy job in the vitreous cavity. So two ways are there. One is to go from the pars plana, make a iridectomy, and through that iridectomy, put the cutter inside anterior chamber and remove all these membranes, and before you go inside the vitreous cavity. So this is going from the pars plana route. So this video shows that how we put an AC maintainer. You put an AC maintainer because the pupil is small, the cannula was not visible. So we put the AC maintainer here, and then put visco to protect endothelium, take this MBR, and take a bent needle and tease away this pupillary membrane, which is generally very huge. And after you have peeled away this pupillary membrane, then go inside the vitreous cavity and do a vitrectomy. So these three steps are always to be followed. This is a couple of patients pre and post operatively after radical vitrectomy. Sometimes the IUL removal may be required during the course of vitrectomy. This was one patient who had plus minus kind of vision, resistant to intravitreal antibiotics. So we started doing the vitrectomy. For a long time, could not see anything, and ultimately had to remove this membrane from the pupillary area. In the process, IUL got mobilized, remove this IUL, and then suture this wound and remove all the exudates, remove all the connections between the corneal abscess and the intraocular cavity. And then do a radical kind of vitrectomy and put in the oil. So this was the same patient after this radical vitrectomy. Fungal endophthalmitis, by and large, multiple vitrectomies are required unless you are lucky that voriconazole may help, or repeated injections of amphotericin. By and large, vitrectomies, multiple vitrectomies are required in these patients. So this is one of post-fungal endophthalmitis, proven fungal endophthalmitis. Pre-acne kind of picture will sometimes require removal of the IUL, sometimes it may respond only to in the back kind of injection. So I'll show three examples. One is which responded to in the back injection of Vanco and Kefta. You see it took 44 days for it to show some response. In this patient, we had to do a partial capsulectomy and vitrectomy. And this patient underwent a total removal of the bag as well as the IUL. So we will just skip this video, which shows the removal of the IUL and removal of all this capsular bag, and do a radical kind of vitrectomy. Vitrectomy after injections is becoming very, very common. because more usage, Avastin or Ozurdex or whatever. So this requires also a real kind of vitrectomy. If the cornea is bad, then you would take the help of cornea colleague. In this patient, temporary keratosis was done and then put a button back. So last is how to tackle, because this unfortunate situation which has happened can happen to anybody. So best is one person only talks to the parent in this media. And but if you want to save from the court case and all, if you document all the findings, you are always on the safer side. It's very difficult to break this bad news. Always have a empathetic attitude towards the patient. And newer antibiotics are coming up which can be used in resistant cases. So thus, keywords are always be on the guard, suspect, react, and act very fast if you want good results, either by injections or by vitrectomy or sometimes revitrectomy. This can yield good results in a lot of these unfortunate eyes. Thank you very much.
Thank you, Dr. Lalit. That was a wonderful presentation as always. Any questions, Srinivas, before we go on to the last speaker?
Anything different do you do in case of P. acne endophthalmitis?
What is that? P. acne?
P. acne endophthalmitis post-cataract surgery.
Yeah.
Anything different do you do from the routine cataract surgery? Like in case if there are deposits on the posterior capsule, do you do a PPC along with that? And how often you have to remove the lens with the bag in these cases?
Yes, sir. Removal of removal of the IOL and the bag is required in around say 20% or so. But by and large, once you do vitrectomy, I remove the entire PPC and irrigate antibiotics from behind and irrigate in the entire bag, because that is important. It's not important to inject antibiotic in the vitreous cavity, but it's important to inject vancomycin in the capsular bag.
Thank you very much.
Thank you, sir.
So I have a quick question, sir, since there are also so many surgeons here. 6 mm cannulas, you're using 23 or 25 gauge?
So this video showed 20 gauge, but nowadays if you have the 23 gauge cannula, but inject straight rather than
Dr. Chaitra, I don't know if I get 25 gauge, but 23 gauge is most commonly available.
No, that's the Alcon one, right?
Yes, yes.
Do you have any information on any other 6 mm available?
I have 25 gauge, but I have not used it.
Who has DORC?
No, DORC.
DORC. So you know if any other people making 6 mm cannulas, because we have a acute requirement, but so many times it's just not available.